The Healthcare Labyrinth Podcast is back for another episode. Join Marc S. Ryan, a veteran health plan and health technology executive, as he explores the world of healthcare.
Welcome, everyone, to this edition of the Healthcare Labyrinth Podcast. My name is Marc Ryan, and thanks to everyone for listening in. We're going to do something a little different today by covering two topics. They're a little bit different, but what they have in common is their potential impact on employer coverage. The first subject is about the direct primary care craze. DPC is a new model heavily endorsed by conservative forces as an alternative to the heavily mandated benefits in the ACA and the exchanges. We will tell you about how the One Big Beautiful Bill Act promotes DPC, what it is, and its pros and its cons. The second topic will be a little longer and cover a proposed bill in Congress that could be very important to saving employer coverage. Employer coverage is struggling under the weight of high utilization and the lack of transparency between employer groups, who are usually self-insured, and the health plans and pharmacy benefits managers they contract with to administer benefits for employees. We'll take 3 breaks. Let's get right to our first topic, the direct primary care craze. While the recent budget reconciliation bill, known as the One Big Beautiful Bill Act, is known for some very atrocious cuts to coverage, some are celebrating the major expansion of direct primary care. Proponents see this expansion as one cost-effective way of expanding or maintaining coverage in the nation. So what is DPC? DPC is a healthcare model where patients pay a recurring fixed fee, monthly or annually, directly to a primary care physician for access to a defined set of services. The model is not technically insurance, and billing does not go through insurance. The physician bills the participant monthly or annually, and the participant has access to all of the limited covered services offered by the doctor or practice. DPC usually offers a defined set of primary care-oriented services, including routine checkups, chronic disease management, acute care visits, and some laboratory tests. The program may include extended hours, telehealth, and other engagement options. Proponents like this model for several reasons. It emphasizes primary care in establishing a strong personalized care relationship with your doctor. There is an emphasis on primary care. It's not only cheaper, but can also reduce the utilization of more expensive services, such as emergency room and inpatient care. There is an ongoing primary care relationship that can control chronic conditions, stop disease progression, and refer to specialists as conditions exacerbate. While specialists are more expensive than primary care, active engagement with a specialist is still cheaper than even higher cost services. Opponents see DPC as limited and nowhere near comprehensive coverage. As well, a DPC may not serve those with multiple comorbidities or severe disease states very well. If DPC is contracted for alone, I sort of agree with the opponents, but DPC can be teamed up with high deductible health plans, HDHPs, or other coverage known as catastrophic coverage. While I still like comprehensive coverage better, DPC and an HDHP would offer reasonably robust coverage. Indeed, many employers are struggling to offer comprehensive offerings right now. And when they do, employee costs due to premiums, as well as deductibles and cost sharing, can be prohibitive for many, especially lower income workers. So these lower income workers either don't take what the employer is offering or cannot really access it if they do. So DPC and HDHPs could offer a solution in these cases. Reasonably robust but cost-effective offerings are better than no coverage at all. With that, we will take our first break, and when we come back, we will close out our discussion on DPC. Be right back.
Health plans and insurance are confusing. Our healthcare system is in dire need of reform. Health policy expert Marc Ryan tackles both issues in his book, The Healthcare Labyrinth. It is both a guide to navigating health plans and fixing American health insurance. Marc dives deep into how health plans and the American health insurance system operate. He then outlines a comprehensive reform agenda for the system as a whole, including pricing, emphasizing health and care management, and ensuring affordable access to health coverage in a private delivery model. Marc is a bit of an unconventional Republican in that he believes affordable access is the morally right thing to do, and that it is also fiscally prudent for our nation. Learn more about Marc's book, The Healthcare Labyrinth, at healthcarelabyrinth.com or search at leading bookseller websites. Available in print, ebook, and audiobook forms.
Welcome back, and we hope you are enjoying this episode of the Healthcare Labyrinth Podcast. We are discussing two topics today: direct primary care and a new bill that could help stabilize employer coverage. So what does DPC remind me of? In many ways, DPC is a throwback to the emergence of healthcare as a social benefit in America. I talk a lot about this in my book, The Healthcare Labyrinth. Way back then, employers battled with the loss of productivity when employees were sick or injured on the job. Employers began contracting with doctors on a per-employee or flat fee basis to care for their employees. The move was not entirely altruistic. It was more about economics, getting someone back to work as quickly as possible. Over time, employers also contracted with hospitals for higher level care that was usually limited. The arrangements with doctors led to the birth of the Blue Shield associations around the country. The arrangements with hospitals led to the birth of the Blue Cross associations around the country. Over time, these regional associations of doctors and hospitals merged, and they then became large insurance entities known as Blue Cross and Blue Shield plans. So what did the budget reconciliation bill do on DPC? Well, the budget bill sought to expand DPCs in the following ways. The DPC and health savings account compatibility in the bill take effect for months beginning after December 31st, 2025. First, the bill clarifies that certain DPC arrangements will not be considered health plans, enabling individuals with DPCs to remain eligible for health savings accounts. Second, DPC account holders can utilize their HSAs to pay for DPC service arrangement fees. Third, there will be some limits to the use of HSAs for a DPC. The fixed periodic fees for DPCs cannot exceed $150 monthly for individuals or $300 monthly for covering more than one individual. These limits will be adjusted for inflation starting in taxable years after 2026. DPCs qualifying for HSA compatibility are limited to offering only primary care services. They cannot include procedures requiring general anesthesia, prescription drugs other than vaccines, or laboratory services not typically administered in an ambulatory primary care setting. So what could the impact of all this be? Well, the One Big Beautiful Bill Act aims to expand access to DPCs by making them more financially accessible to individuals who utilize health savings accounts. DPCs will grow both individually but also as an employer offering. While not right for everyone, combining DPCs with HSAs and HDHPs could be a reasonable alternative and meet the Affordable Care Act's definition of minimum essential coverage. So why will DPCs grow? Well, as I indicated, employers have seen huge utilization and cost increases the past few years. Trends are running between 6% and 9% per year, and the increases will continue in the future. While employers have sought to shelter employees from massive increases in costs, recent surveys seem to indicate that employers now will need to pass on more costs to employees. in premiums, deductibles, and cost sharing. Smaller employers may look to DPCs with HSAs and HDHPs to lower their costs as well as those of employees. Creative funding by employers may emerge, where employees fund the HDHPs, DPCs, and also help fund the HSAs. The GOP also wanted to expand the concept of individual coverage health reimbursement arrangements, or ICRAs. In this model, employers fund the HRA to allow employees to purchase their coverage in the individual marketplace. The ICRA concept will grow as well, but perhaps less so due to the expiration of enhanced premium subsidies in the exchange, and what could be huge premium hikes there. The House version of the One Big Beautiful Bill Act had some expansion of ICRA, but it was stripped from the final bill in the Senate. With that, we will take our second break, and when we come back, we will begin our discussion of the Employer Coverage Reform Bill. Be right back.
Lilac Software is proud to work with the Healthcare Labyrinth website to educate people on the healthcare system. At Lilac, we believe transparency is so important in healthcare. The healthcare system is opaque, and Lilac is trying to bring clarity to data and unleash the best member care, reduce costs, and improve outcomes. Our cloud-native payer platform revolutionizes data insights and analytics. Plans have all the data they need, but in silos locked away in point solutions. At Lilac, we solve the data fragmentation problem and help plans turn complex data into actionable insights, leading to greater operating leverage, tight cost controls, and healthier members. Health plans can improve STAR scores, reduce medical expense, drive revenue, and more. Quite simply, with Lilac, you can drive better business and health outcomes. Learn more at lilacsoftware.com.
Welcome back, and we hope you are enjoying this episode of the Healthcare Labyrinth Podcast. We are discussing two topics today: direct primary care and a new bill that could help stabilize employer coverage. We are on to the employer coverage issue now. I call this chopping away at the thicket of the employer coverage quagmire. This new bill could bring unprecedented transparency and reform. Employer coverage costs have been growing profoundly the past several years. Again, average annual hikes have been between 6% and 9%, and 2026 could see spending hikes at the top of the range. A great deal drives the consistent high growth in employer premiums and costs. First, employer coverage pays the highest rates to providers due to lower Medicare and Medicaid rates. This is known as a cost shift. Second, employers are seeing heavy cost and spending hikes due to medical, specialty, and retail drug utilization and price hikes, especially the broad adoption of GLP-1s for both disease states and weight loss. Third, utilization post-COVID pandemic has been very high. Fourth, health plans work with hospitals and other providers to trade higher commercial rates in favor of lower Medicare Advantage rates. Why would they do this? Well, because MA should be a high margin business with very high premiums. So lower provider rates in MA help drive MA margins. It is easy to give away dollars on the commercial side because plans are either not at risk in about 2/3 of situations because employers are self-insured, or can pass on the higher costs in the form of premiums in about 1/3 of cases where health plans are at risk. Fifth, vertically integrated health plans enter into non-arm's length arrangements with related parties to raise price and retain dollars within the broader company enterprise. This actually impacts all lines of business. And sixth, employer coverage is dominated by large national health plans and blues plans. The market, therefore, is less competitive than it should be. Notable settlements in the blues world were entered into to break down the near monopoly the blues have in many states, but the settlements may do little. There is one other major culprit, and that is that employers lack understanding of the costs of the arrangements they have with health plans when they are self-insured. Health plans usually acting as administrators do not disclose various underlying costs to the employer groups, and many employers are none the wiser that they have inefficient and bloated arrangements with health plan administrators. This has led employers to demand more transparency, although health plans and pharmacy benefit managers, who sometimes have separate contracts, continue to shroud their financial arrangements in secrecy. Plans, too, are attempting to break up various services into multiple contracts, although the lack of transparency persists. With that, we will take our last break, and when we come back, we will continue our discussion of the Employer Coverage Reform Bill. Be right back.
The Healthcare Labyrinth is no ordinary website. It features news and commentary from one of the nation's leading healthcare policy and technology experts. Marc Ryan combs the internet for the latest healthcare news and publishes a news feed each weekday with summations and Marc's insights. Twice a week, Marc publishes a blog to go deep into a current issue. And of course, Marc hosts a podcast each week to delve even further. All of this is available at healthcarelabyrinth.com. Visit each day for the latest happenings in healthcare. As well, learn more about Marc's book, The Healthcare Labyrinth, at the website. That's healthcarelabyrinth.com, your go-to source for healthcare news.
Welcome back, and we hope you are enjoying this episode of the Healthcare Labyrinth Podcast. We are discussing two topics today: direct primary care and a new bill that could help stabilize employer coverage. We're discussing the employer coverage issue. Let's talk about this new reform bill. The new bill could serve as a major impetus for reform of the self-insured employer coverage world that is governed by the so-called ERISA statute. Again, the majority of employer coverage arrangements are where the employer group is self-insured and the health plan acts as a third-party administrator. The bill, sponsored by Senator Roger Marshall, Republican of Kansas, who is also a doctor, and John Hickenlooper, a Democrat of Colorado, is called the Patients Deserve Price Tags Act. It has a broader mission than just employer coverage. It seeks to strengthen and codify existing hospital price transparency rules to require actual prices, not estimates, expand to other care settings, impose greater penalties for noncompliance, and attestations of accuracy and completeness as to the prices. It also would require a detailed explanation of benefits by all commercial healthcare plans. This includes itemized bills by providers. On the employer coverage front, the bill would do the following. It would require unprecedented transparency for all health plan middlemen. Employer and union group health plan, TPAs, would have to provide detailed information to the employer plan on claims and financial transactions of their subsidiaries and subcontractors. This includes all provider reimbursement methodologies, including pricing formulas, fee schedules, modifiers, repricers, various fees, rebates, discounts, and any other contractual or subcontractual terms used to determine payments to providers and subcontractors. It also requires all amounts paid to subcontractors, including whether on a fee-for-service, incentive or bonus, shared savings, bundled, administrative, capitation, or value-added risk or alternative basis. It also bans gag clauses and confidentiality agreements that prevent employers and unions from accessing data on their members. It requires health plans and TPAs to provide full, de-identified claims data, including medical, pharmacy, and encounter claims, to employer, public sector, and union plans at no cost. I would note that the Consolidated Appropriations Act of 2021 did prohibit gag clauses by health plans that stop employers and plan members from seeing price and some other data. Several employer groups have sued plan administrators to gain access to claims and data. Employees also have begun suing employers, arguing self-insurance funds are in breach of their fiduciary responsibilities to run a cost-effective and quality health plan. Thus, the Consolidated Appropriations Act reform was clearly not enough, and the proposed bill is clearer and goes much farther. The benefits are very clear. Tired of the skullduggery of current arrangements, employers continue to plot more efficient and transparent self-insured models. The bill would propel the remake of employer coverage. For the first time, it would make employer groups knowledgeable on real costs and empower them on rate negotiation. The bill would also promote more competition. In the end, the black box methods employed by TPAs and health plans and PBMs could be broken up. In truth, employer coverage is in a precarious state. It cannot face the huge trends for too long. While businesses have tried to absorb most of the increased cost, I've told you that employees will have more and more cost moved over to them. The bill comes at an important time and should pass. With that, we will conclude this edition of the Healthcare Labyrinth Podcast. See you next week. Take care.
Thanks for joining Mark and the Healthcare Labyrinth Podcast. Go to healthcarelabyrinth.com each day for the latest healthcare news. See you next week on the next Healthcare Labyrinth Podcast.